that I did not know previously. So, well, it's 12:35. We're going to go ahead and get started. This is the Clinical Consultation Network. We do this every Tuesday at 12:30. We're lucky enough to have a great guest with us today, Dr. Matt Holder, who is the director of the Lee Clinic in Louisville, Kentucky, and now is getting ready to open a new clinic in Nashville, Tennessee. Yes, the Kramer Davis Clinic. We're going to get into all that in just a minute. So, but I'm so happy to have Dr. Matt Holder here as our guest today. I'll just talk to you a little bit about what we've got upcoming on CCN. Next week, we've got Karen Harvey, who will be here. She's an expert on trauma and healing. I've heard Karen speak on numerous previous occasions. This will be her first time being a guest on Clinical Consultation Network. That's a bit of a travesty, but I'm so glad that she's going to be here next week to talk to us about trauma and healing. And then on July 25th, we've got our fourth Tuesday feature, which is a NAD collaboration. Many may not know that I'm the president of the NAD organization, and so we have one of our board members come on each week, each month, and to talk about the good stuff, which is their new manual on therapy for people with intellectual and developmental disabilities. And I'm talking about Dr. Uzama Price and Dr. Dan Baker. They are co-authors of that book. And they're going to be here to talk to us next week or on July 25th about that. For August, we're still trying to get our guests together, but we will have some guests lined up and be prepared to do that starting on August 1st and throughout August and the rest of the year. So that's what we have upcoming on Clinical Consultation Network. Now for our Get Smarticle. And I'll forecast that this is a great article, I think, but I did not get to see the entire article. All I was able to see was the abstract, but I'm going to talk just briefly about this. And Matt, you may refer back to this later when we're having our discussion. But this is by Behrens et al., and it is the preliminary results of an interdisciplinary behavioral program to improve access to preventive dental care for adults with intellectual and developmental disabilities, a very important topic in this article. And so a summary of this is that adults with IDD, I think we all know that they often experience significant oral health disparities, partially because of behavioral issues that they experience when they go into a dentist's office. And so as a result of that, there's often a lot of sedation that occurs. You know, there are practices set up to do sedation dentistry, as a matter of fact. Sometimes people have to undergo general anesthesia to get their dental care. Other times they may have to be restrained to receive their dental care. And so these are not great outcomes for people. We want people to be more participatory in their health care. And, you know, as a result, also probably getting better dental health care if we're able to avoid some of those approaches to treatment. Next slide. So the review findings were they had 32 active participants with IDD in this study. 15 of those were able to successfully complete a full dental exam with behavioral interventions and no sedation or restraint. So that's a significant gain when you're able to do that. And I think, was there a slide prior to that one, Babs? I'm sorry. Okay, I think what I failed to mention here was that this was an interdisciplinary approach to this that involved the dentist, I think the primary care provider, and a behavior analyst that were working together to create these programs. And so the behavioral interventions worked for 15, 17 at the time that they wrote this article were still in treatment, so they weren't able to report their final results on those. But having 15, about 49% of those participating in the study that were successful was a significant step forward. Next slide. So the conclusions are interdisciplinary care. Interdisciplinary care can help people be better participants in their oral care. And as a result of that, this is, you know, I think the coup de grace is that as a result, people may experience fewer oral health problems. And that is something that's very important. I think, once you start getting into oral health problems, where you thought you had a behavior problem before, it gets so much worse if people are experiencing these types of physical health conditions like oral health problems. So, Matt, that's a perfect entree to what Kramer Davis is going to be all about, what Lee Clinic has been all about, the things that you've been doing for many, many years.
Yeah, yeah, it is actually. And that article actually, three of those authors there I've worked with very closely: Cynthia Peacock, David Frey. So Cynthia Peacock is a internal medicine physician. David Frey is a dentist. Ben Warner is a physician and a dentist, I believe. But they're down in Houston, and we've talked quite a bit about this transdisciplinary approach to providing dentistry. And what you said is exactly right. There is a better way to provide care to the population. That's just what it comes down to. The OR, when it's employed in dentistry, is really a means of a last resort. Typically it's going to happen once a year. And our experience has been at Lee, and I can certainly tell you the story about Lee, but our experience has been that there's a benefit to seeing our patients more often than that. Oral hygiene tends to be an issue. So, having more frequent visits, more frequent oral hygiene, more frequent oral hygiene instruction, more frequent touches with the families and the caregivers about oral hygiene, because that, prevention is the most important thing we can do. If you wait, if there's a problem and, a person isn't brushing their teeth properly or can't get their teeth brushed for some reason, and you wait for an entire year, well, not only is that going to be a very expensive operating room visit because you're going for general anesthesia, but also you're going to have to do a lot more, and a lot more teeth are going to be lost, and a lot more pain is going to be felt during that whole year, and the whole cascade of things,
Yeah, that's a very interesting article. And before we launch too far into the topic, I wanted to give you a little bit of an opportunity to introduce yourself and tell us a little bit about your and where you came from, where you've been, where you're going, those types of things. And no, I hope Babs told you that we wanted to extract one interesting fact from you as well about yourself that nobody else might know. Of course, I always forewarn people, don't give us too much information, but just enough to tell us something that others might not know about you.
Well, I think it's relevant for this discussion. I actually don't advertise it a lot, just because I grew up in this space, and my professional career has been working with people with intellectual and developmental disabilities. And I was probably in the field I'll use air quotes, as an expert for 10, 12 years, something like that, before my first daughter was born. And when she was 3, she got the diagnosis of autism. So I got to experience the parental side of all of that. And, I've got to tell you, one of the most humbling and just intellectually interesting experiences for me was, having been on the medical side of this and having been on the provider side and guiding people through what was a broken system, but on the adult side. And then now I'm in the child world and trying to guide our family through it. And it's a difficult system and it's very complicated, even for somebody who knows the right questions to ask, and a lot of the people to go to. And I mean, it's really complicated. So it's been really eye-opening, but also great to have that perspective of a parent as well.
Yeah, that must really inform the work that you do. I mean, to have that. I was referring back to telling my wife about this movie with William Hurt called The Doctor, where he had been a surgeon and had this really ribald approach to his patients that was not very sensitive. But then when he got cancer, he became more sensitive to the needs of his patients. And it sounds like that's a sort of a similar journey to what you've had here. I'm
Yeah,
not implying that you had a ribald approach to people before that, but you know what I mean. I think you understand the issues more clearly than I think most people would.
yeah, you just sort of experience it in a different way, and and in some ways it strengthens your resolve to try to change the systems,
Yeah.
that are broken. That was really why we founded Lee, Lee Specialty Clinic, and why we're coming to Nashville with Kramer Davis Clinic. But yeah, I guess I can go into that topic.
Yeah, tell us a little bit about the Lee Clinic and how it got started, and
Yeah.
what your approach was there.
So I got out of medical training in the early 2000s, about 2001, 2002, and I had been in internal medicine, and really it wasn't quite doing it for me professionally. I felt that it was kind of a cookbook, if you will. Like, we have a certain formula of things we have to go through. I had never even considered this population, quite honestly. I didn't know anything about it, as most physicians don't know anything about it when they get out of school. We've done lots of surveys on this, and we find that most physicians and dentists and healthcare providers just don't get anywhere close to the right kind of training for this. I came out knowing absolutely nothing, but I was introduced to some people who were already in the field and had been doing a few things, and went to a couple of events where I got to work with people with intellectual and developmental disabilities. I got involved with Special Olympics, and it really just changed my outlook on, doing something for the right reasons for a population who really needed it. And I could see it. I mean, I could see clearly where my colleagues and I could really try to change the system and try to make a difference, because it was so obvious that things were really not going well, and the system just wasn't designed, especially on the adult side, for this patient population and for these individuals. And so seeing those glaring problems, I thought, well, this looks like the thing for me. So we started our first clinic. I partnered up with Dr. Henry Hood, who's a dentist, who was one of my colleagues, and also have a family relationship as well. And so it's like working with family is really neat.
I've
worked with people
often referred to the two of you as Hawkeye Pierce and BJ Honeycutt of our field. That's the way I because you guys take such an advocacy, the role of an advocate for people, which I felt that was what those characters did, and I really feel like that's an apt comparison.
It's actually a great analogy, because as I recall I used to love that show. As I recall from the show, they also had kind of a cavalier attitude about, let's just say, the way things are, the Army way, or
Right.
the way things are done, and the system they were in.
Yeah, we hate that. Yes.
And so they kind of looked at it, and they were always very much pro-patient. They were going to get it done no matter what. It didn't matter if the rules said they couldn't. They were just going to be out there and get it done, and they were doing it for the right reasons. And so,
That's right.
Yeah, you're right. That's kind of it. I mean, funny enough, when I first got into this field, I had no way of even having a paying job. It just didn't exist in the adult side of intellectual and developmental disabilities, unless I wanted to work at an ICF or something like that. But that wasn't really my cup of tea. And so the first 3 years I was in this field, I lived below the poverty line, which is an interesting way to get into a field. I just wasn't getting paid, and I knew I'd figure it out one day, but it was definitely a passion, and I was doing it for that, and certainly not for the paycheck. And having that experience, well, it really, I don't know, it helped me to sort of laser guide my focus into the things that mattered, I feel like. So we started this clinic in 2002, and really started getting going around 2005. And it was a dental only clinic to get started. And we were going to mix in some some, medical things. And the reality is we couldn't figure out even how to deliver care to this population. There was no way in the state of Kentucky, working for most of the population is on Medicaid. Most of the patients that we wanted to see, those with, I call it complex intersectional disability, but these are individuals who have multiple layers of disability sort of overlapping on top of each other. Those patients that we wanted to see, they generally take longer, they have more complex cases, more things going on, and just being able to unravel all of that and provide the right kind of care, it takes a lot more time. Meanwhile, Medicaid typically pays a lot less than on average. So, the business economics of this don't work really well. We worked out a special deal with our state government, and they gave us a tiny grant to get started. And so that helped fill the gap between, the system and the idea. And I remember early on they said, hey, if you get 100 people to come to this thing, that'll exceed our expectations. I think within the first year we probably had 500 or 600 people, and they were coming from 3-4 hours away, driving each direction for a dental visit. It was clear that there was a serious need, and it didn't take long. I mean, within 2 years, the state had said, you know what, maybe we should expand this and really try to provide the right model to the patients here. So we kind of started working on that and brought in medicine. We had a lot of hurdles to climb on this. There's a lot of bureaucratic things you have to do. There's how are we going to pay for this? Where's it going to be? There's, just all kinds of different moving parts. But eventually, the state built a nice clinic for us. We got it launched in 2014. So it takes a while to get these things, these new things that are sort of out of the box built. But that's what it is. And but in 2014, we launched it. Medicine, dentistry, psychiatry, PTOT speech, behavioral analysis, psychology, nutrition, gynecology, podiatry, audiology. We've offered a lot of things at that clinic. And initially, and I'll say the idea, kind of from Henry and I originally was just, hey, let's just do medicine and dentistry. And wouldn't it be great? Wouldn't it be convenient for the patient if they could come to the same place and get that care? Wouldn't that be great? What we figured out after about 6 months, or maybe a little bit longer, was that very quickly, because we had all these disciplines in the same place, they were learning from each other. And, it wasn't like in a typical medical setting, you've got, 11 internal medicine doctors, right? So they can talk internal medicine all day, but they're just going deeper and deeper into internal medicine. We took sort of the different approach, which is we have all these different disciplines, and we only have one internal medicine doctor, but they're going to talk with your behavior analyst, and they're going to talk with your dentist, and they're going to start learning how all of these things fit together and provide hopefully a better, sort of more whole person guidance for taking care and health. And so that's what we learned in that. It became pretty successful in terms of the patients that we were able to bring on, the results that we were able to see, and it formed the basis of what would eventually become Kramer Davis, which is the thing we're going to be opening up in Nashville.
Yeah, just one more thing on your clinic, lead clinic, because you can have all the disciplines there, but you've got to create a circumstance where they actually engage one another and work together on things. And I remember back when I first started, there was a surveyor that came to a facility where I worked, and they said, well, it's as if everybody's got a blindfold on and they're holding a different part of an elephant and describing the part of the elephant that they're holding on to, and not working together, not taking the blindfold off and seeing what the other people are describing and dealing with. And that's the only way you can understand the whole person, is to be able to do that. You've employed that in your clinic to a high degree. Tell us a little bit about how you've created that environment within your clinic.
Yeah, that's a really interesting thing because a lot of clinicians are not taught to work with clinicians from a different discipline. Physicians sort of are comfortable talking to other physicians, but you start talking about teeth or whatever. Well, that or sometimes the behavior analysts maybe they don't feel comfortable talking to a physician, or sometimes I'll just insult my own community for a second, but sometimes physicians can be a little bit arrogant about who's giving them their information.
Behavior analysts, sometimes they think they've got the whole answer to everything. There are some
right.
like that.
Right.
It takes a while to learn. Well, maybe I need to listen to these other folks.
Right. Yeah, a little humility, right? And I think part of getting that group together and the transdisciplinary nature of it, part of making that successful is having the right types of the right outlook, the right, I don't know if it's personality is the right thing, but the right approach from each individual person. The idea that you can learn something from everybody sitting around the team, that you are going into a situation where when we're doing this interdisciplinary thing, we are taking on very complex cases where no single person, you probably didn't learn how to do this in school anyway. So, you have to come at this with I'm going to learn, and I'm here to soak up information. I'm here to work with this team. I'm here to, solve problems. And I think it's a matter of having, there are certain people who are, I guess, geared toward a common goal. Some people are, we used to call them gunners in medical school, right? There are people who are just like hot dogging out there, they're trying to be like the best of the best of the best. And it's all about them, and that is the absolutely wrong approach, for this population. We need the people who kind of leave the egos at home. And because quite frankly, we say it all the time, if you are, in this field for very long, you'll find out that you're going to be made to look like you don't know anything every single day, because the situations you get can be very complex, and so you have to go into this with some humility. And part of getting that transdisciplinary team to work together, when we're looking for people, and it's not always about well, how many articles have you published? What school did you go to? The academics and all of that. It's when we sit down and hire people, when we're looking for people, the most important part for me is, I call it the right brain interview, but it's a matter of, you're going to tell me something, but how are you telling it to me? That makes more difference to me than anything, because a lot of our patients, have a different method of communicating. Maybe they have the verbal understanding, maybe they don't, but they certainly, almost anybody can look at a person and decide if they like how they are, not what they're saying or, but how they're saying it. And so to me, there's a lot of nonverbal communication, a lot of nonverbal skill, plus that ability to cooperate that kind of merges together. And that's how you form a really good team, I think.
Yeah, I've been using the term interdisciplinary, but you've been talking about a transdisciplinary, which is actually another step further from interdisciplinary. Tell us a little bit about what that term means and how you apply that.
Yeah, it's funny. We've kind of come along this journey. When we first opened, what I was describing was, our vision was a multidisciplinary, which is essentially, almost two completely siloed, medical and dental, and, maybe there's a tiny bit of overlap. And then what we started to understand was, well, we're actually more of an interdisciplinary. So people kind of, talking to each other, and there's a little bit more interweaving of schedules and cooperation among the different disciplines. But then this idea of transdisciplinary is one that I was introduced to a couple of years ago, and I realized, oh yeah, that's actually more of what's happened. And that's really in the sense that now the actual way that the different disciplines, the healthcare disciplines, practice has changed and is almost something different. So, if it's interdisciplinary, maybe your internal medicine doc or maybe your physical therapist, they're still very much practicing what they've been taught, that discipline. In the transdisciplinary world, they've now incorporated some aspect of those other disciplines into their practice in a pretty deep way. I mean, we think of it as almost a specialty. I mean, in Kentucky, we call it the Lee Specialty Clinic, and I refer to all the people that are providing care there as specialists. It's dentistry is one thing. Dentistry with this population is a completely different animal. And for those who have been in it, they have successfully taken away something from all of these other professions. In fact, if somebody comes to do a rotation at our clinic, so the Lee Clinic is a teaching clinic in about 18 different healthcare disciplines. And when somebody comes to if we have enough time for them to do a rotation, half of that rotation is spent not in their discipline. And that's the way that we do it. So if you come for dental as an example, your first day is probably going to be with physical therapy, occupational therapy, behavioral, psychiatry. You're going to go through and rotate through all these other things before you even actually get to the thing that you do. So that you have that context of the greater whole person, how these things can fit together.
Yeah. And so all of this has given birth now to the Kramer Davis Clinic, which we're so excited about coming here to Nashville. Tell us more about the Kramer Davis Clinic, how that idea came about. I remember, I will say, I'm kind of going back in time a little bit when Dr. Tom Cheatham and I visited the Lee Clinic, and we were talking about, even at that time, trying to bring something similar to the Lee Clinic to Tennessee. And we're so excited now that is actually coming to fruition. Dr. Cheatham, of course, died a few years ago, but this was a major thing that he wanted to accomplish. And I'm so happy to see that coming to fruition now with the Kramer Davis Clinic. Tell us a little bit about how that came about and what you're trying to accomplish here in Nashville.
Yeah. Tom was an amazing man, an amazing doctor. I really learned a lot from him over the years, first when he was in Canada and then when he came down to Tennessee. And he was always, he saw the vision. And I think like a lot of folks who've been in the field for a while, they can clearly see what needs to change. It's just about getting the system to sort of, figuring out how to navigate all the things that it takes. It's interesting coming from Kentucky and Tennessee, right? I mean, we're neighbors, geographically, we're not that different, of states, and
we like to talk about one another, but we are very similar.
Right. And you would think that it would be really easy to take, an idea in one state and move it into the other. But healthcare is probably the most complex industry that we've got, as it's huge and so many different rules and so many different ways of doing things. In the long and the short of it is, I think, Cy came down, you came down, Dr. Cheatham, Patty Killingsworth at the time lots of folks, came and saw it. Wanted to get it going, but it was really complicated to figure out, well, how are we going to get from here to there? In Kentucky, we had a unique method of paying for it. Just to give you an idea, and I won't go too much into the business part of it, but it takes 4 times as much, like just dollars. It takes about 4 times as much for us to provide what we provide than what Medicaid or Medicare or private insurance, like all combined, will reimburse. And that has to do with all the time that we spend. When we're talking, the article that they talked about, right? Those behavioral interventions, as an example, are an unsuccessful, in the eyes of a dental payer, they're an unsuccessful dental visit. You might go through 8 of those visits and not fill a single cavity or, not take a single x-ray. you may actually get nothing done on those from a billing standpoint. So from a business standpoint, it's just, lost revenue is
Right.
kind of how that looks like, right? And so what it really takes is a different way of looking at the population. And quite honestly, what I've seen over my career is the impact of the fee-for-service system on people with IDD. A straight fee-for-service, you get paid the same amount as a physician, you get paid the same amount of money whether you are dealing with a complex case or a simple case. Whether you're dealing with somebody who is, completely verbal, can advocate for themselves, or nonverbal and can't advocate for themselves, you get paid the same amount of money for doing the same thing. From a business standpoint, what just invariably happens is practices are geared toward those easier cases, and they just don't. It just doesn't work out for when you have that system. And so we have to figure out a way to look at this from a global standpoint, from a different way. And what we started to realize was, when we were working with at Lee, we started to realize that, we are saving the healthcare system a ton of money by not having these horrible outcomes that come to us, that come to us in crisis. And, I can't tell you how many times we've had patients and, hey, when was the last time you went to the dentist? Oh, it was 17 years ago.
Oh,
And their mouth is just, and because they've gotten rejected from every dental practice that they'd ever gone to, and the system wasn't working for them, or if they went, they were going for general anesthesia for, routine dental cleaning.
Mm-hmm.
Same thing on the medical side. What ends up happening is these individuals, because the system isn't really set up for them, a lot of the care gets delayed. A lot of the diagnoses are wrong. There's a lot of pharmacy, a lot of drugs that are being prescribed that don't need to be there. And when all of that delay happens, the next thing that comes in is, well, there's a safety net somewhere. I can't get into my primary care doc, so my primary care doc doesn't want to see me unless it's after hours, or something like that. And I can't get into the dentist because my dentist doesn't, know what's going on. And anyway, they end up at the emergency room, suddenly, because there's been all of this, I'll call it systemic neglect. And they end up in the emergency room, behaviors, and the emergency room docs don't know any more about this population than anybody else coming out of medical school. So they're more than happy just to throw some more behavior management drugs at it or whatever.
Yeah.
And you see more emergency room visits, you see more hospitalizations, and this goes all the way up to, let me tell you this, if you don't mind. I just had this happen to me last week, and it's still like burning. This is in Kentucky, but, I got a call from, we had an individual who went to the hospital. He had a BMI of 12, so extremely undernourished, extremely, at death's door because he wasn't eating. But what had happened was he wasn't being fed. The hospital just looked at him and they decided they were going to put him on hospice. And, end of life, they weren't feeding him. They weren't going to try to tube feed him. They weren't going to give him an IV. They weren't doing anything. And when I talked to the doctor who knew nothing about the population, he said, we just have to treat this like an end-stage dementia patient, because in his mind, what he saw was somebody who was nonverbal. And in his mind, you don't become nonverbal unless you've had something massive happen to you. Well, this person's been nonverbal their entire life, and he's 60 years old, and to see, that kind of a mistake. And I said, that was the lens that they were coming at this with. And, I've seen people being put on hospice care for urinary tract infections, right? Where they had a little bit of mental status change because they had a urinary tract infection, and the doctors completely misinterpreted that. And, this is what we're dealing with. So let me bring it back now to what we're doing with Kramer. So the idea is the way that you structure this and the way that you pay for this whole thing is to look at, it's really expensive to provide a group of people really bad care. And then, and such that the only thing that catches them is the safety net. And by that point, you're talking about ICU visits, which by the way is the number one thing that happens to this population when they go to the hospital. That's so if we can figure out how to look at this holistically and shift what we're doing from, way after the fact, delayed and expensive hospital visits and getting into instead prevention and primary care, we shift where we're spending it, and the people are significantly better off. And quite frankly, we're probably spending less money even in the healthcare system. So everybody should win in this.
Too often we're going from emergency to emergency to emergency, which is taxing and expensive to do.
Yeah.
And the whole idea really needs to get back to prevention. Now, I'd like to think that you named the Kramer Davis Clinic after me partially, but I know that's not the case. You named it for a particular reason, Kramer Davis. Why don't you tell us a little bit about why you named it Kramer Davis?
Yeah, well, Davis is a great name, so feel free to come on by any time. But yes, it's named after two of our patients, and also technically owners of the company as well. So Trey Kramer and Terrence Davis are, and they don't mind me using their names because this is as much their deal as
their
it is
enterprise.
ours.
Yeah.
Yeah, it's a whole thing. But they were patients of ours, and kind of early on in our formation, and both I would say are not quite nonverbal, but very low verbal. I would say autism is a feature in both cases. One has a significant physical disability as well. And what they did was show us the importance of this transdisciplinary approach. I consider them to be probably our best teachers, better than any medical school teacher that I had, because in order for us to, really in order to do what we could, to do with them and get their health to the best place possible, it took this whole team and this whole approach and learning how to work together and learning how to work with the families and learning how to work with the individual and their support system and everything around them. You branch outside of the clinic. You start reaching into the home and into, employment settings and, any setting where there's an issue or not an issue. You're just trying to optimize the whole state of existence. So that's who we named it after. We also wanted to give it let people know that this is our orientation. It is truly the patient first. It's the center of everything that we do. We had a lot of people come to us with these fancy, that sounds like rocket ship names or, an electric vehicle or something, give some sort of like fancy, futuristic clinic name. But, we just thought, let's just name it after the people who really taught us how to do this.
Yeah, you could have easily named it the Holder Hyde Clinic, but I think your naming of it represents what you're all about, which is really doing good quality care for the people that we serve, and that's so important. Tell us a little bit more about where the clinic's going to be and any of the parameters, the nuts and bolts of how people can get care at the Kramer Davis Clinic.
Yep. So the clinic is going to be, it's located in Hermitage, and we're still putting the finishing touches on it. It's at, I'll give you the address, it's 3901 Central Pike, and we're going to be on the 5th floor there. But it's by the TriStar Hospital campus. In fact, it's a medical office building that's right there on that campus. We thought that having a nice partnership with the hospital would be very helpful because, we can, and we've already started talking with them, but we can kind of help to, I don't know if train's the right word, but, have discussions with the hospital about, how to work with our patients. And also, likewise, they've already called us on a few patients, where there are discharge issues and, just getting out of the hospital can sometimes be complicated. And so, that's one of the things that, we're really excited about. As far as the patients go and how they can be, part of the clinic, I think it's really important to note that right now our partnership with Blue Cross Blue Shield is exclusive, and so if you want to come to the clinic, you need to be part of the Blue Cross family. And so, we're still talking with the other insurers, and maybe they come along, but Blue Cross have been with us from the beginning, and so just gonna say that that's gonna be the way to get in.
We hope the other two will come along at some point and be able to be part of this. But Blue Care has been your partner from the outset and is really fueling a lot of this that you're doing right now.
I will say they've been incredible to work with, very innovative, and very understanding of what we're trying to do. And, this isn't without risk for them too. This is this is a new thing. And it sort of hit me the other day, your typical insurer, the whole business is risk mitigation. You're trying to take, somebody's significant risk and pool it together and try to reduce that risk, to ask an entity whose job is to minimize risk to take a risk, on doing something better. That's a big ask, actually.
Yeah.
And, but Blue Cross has been fantastic about that. And they just really get it with the population. I just can't say enough good things about them. We're expecting, I'm going to say it now, I hope that fingers crossed here, that we can keep to this date, but September 6th is the day that we hope to start seeing patients at the clinic. We'll probably have that'll be our soft open. We'll probably have a grand opening a little bit later on, but it's and I believe that Jamie has put some information about our website as well. So people can start reaching out now. We're still trying to get all of our systems in place. We've got a couple more months, and as you can imagine, there's a lot of hiring and systems and things to get a lot of moving parts to get all put together. But I think that within the next 2 months, we're going to have our doors open and we'll be seeing patients. And they can contact me as well personally. I've already had some folks reach out to me personally, and I'm glad to get them, get their name and just start trying to, get people into the clinic.
Yeah, I highly encourage people to look into it and to become patients there, because it is it's state of the art care. I mean, that's what you're really offering here, and especially your affiliation with the hospital, I think, is also just a big plus that you have. And so I am wondering a little bit now about how we move forward from here. So you got your 9/6 opening. You've got, if people currently have Blue Care, I think that's going to be that's going to be the entree at this point. Hopefully the other insurance folks come along soon. But I am so gratified that we're going to have this in Nashville, Tennessee. I just can't say enough about how great this is, and how much I applaud yours and Henry's stick-to-itiveness in getting this done, because it has, I know it's been an effort, and we've been talking about it for years, and now here it is coming to fruition. Babs, do we have any comments from the chat box?
We've just Jamie posting things. Amy. Oh, we're starting to get some. Amy just said, this is great. Fantastic move. So needed. This one says, Dr. Holder, I'm the behavior analyst at Middle Tennessee Mental Health Institute. I believe we have several patients at our hospital that could benefit from the services your facility offers, in particular dental work. I would love to get contact information to connect you with our facility medical director. Jamie, can you put his contact information in there?
I'll add that right now.
Thank you.
Thanks, Jamie.
Sorry if I disturbed you all.
I've got my son here with me as well.
Oh.
Sorry. We got another comment that says offering case management at the clinic since there's so many. You got to be quiet, buddy.
Yeah, so typically what we will do is work with, if there's an existing case manager, we will work with the existing case manager. We kind of do things a little bit differently at the clinic in terms of case management. Our focus mainly is medicine, and so we will have nurse navigators to kind of help. Inside the clinic, it's pretty easy to coordinate because that's what we do inside the clinic. You should be able to do it inside your own walls. Outside the clinic, then it'll take a little while for us to develop that network of specialists, but the community is usually really good about letting us know who the good doctors are that we can refer to there. And so each one of our clinicians is concerned about these, referrals and what it takes to sort of bring all these things together. So we will have that sort of nurse navigator model. And if you come to us with a case manager, we'll certainly work with that case manager as well. That's not our primary thing. Our primary thing is getting all of these healthcare disciplines, together and to work together. And we sort of have a unique way of going about doing that. And we also don't want to disrupt anybody's current system that's working well. If they have a good case manager they work with, we don't want to replace that person.
Yeah. Well, Dr. Holder, thank you so much for being here with us today to talk to us about the Kramer Davis Clinic. Again, I am so excited about what is going to be coming here and what we're going to have here. It's just another piece of the puzzle that we need to plug in and to have available for folks. And so happy that you stuck to it and got it done. And I'm very anxious for you to open your doors and get started. So thank you so much for being here today.
Well, thank you, Bruce. I really appreciate it. I appreciate the support that you've given us too over all these years. And it's just great to see that this thing's actually going to open our doors and be able to start serving the people of Tennessee. So thanks for giving us the opportunity to talk about it today.
Yeah, thank you. And thank all of our audience for being here today. This is the Clinical Consultation Network. We do it every Tuesday at 12:30. So join us again next week for another fascinating episode. And thank you again, Dr. Holder, for being here today.
Thanks so much. Take care, everyone.